Over to you, Shruti.
Great. Good evening, everyone, and welcome to this wonderful webinar series brought to you by AFPI, Academy of Family Physicians of India, Karnataka, and Project StepOne, which is an interaction between family physicians and the public to commemorate World Family Doctors Day. Hello, doctors, wishing you all a very happy World Family Doctors Day. And I must thank you all for the care you provide every day to all of us. So during this session, the panelists will speak briefly about the specialty of family medicine, and as family doctors serve as an expert resource to health-related concerns and queries from the public. During this interaction, you can also ask these trusted experts any questions related to health. It can be in Kannada. You can type out your questions in Kannada in the chat box. You can do it in Hindi. You can also post your questions in English in the chat box. Right. I welcome Colonel Dr. Mohan Kubendra, who is the National President-elect, Academy of Family Physicians of India. I welcome you, sir. Dr. B.C. Rao, who is the mentor for Academy of Family Physicians of India. Dr. Ramkrishna Prasad, who is the Vice President of Academy of Family Physicians of India, Karnataka. Dr. Gauri Chintalapalli, who is the Executive Committee member and Treasurer for Academy of Family Physicians of India, Karnataka. Welcome you all, doctors. Thank you so much for making time and coming on to the panel. Before we proceed, let me give a quick introduction on Project StepOne. Project StepOne is a non-profit collective of technology and healthcare professionals on a mission to augment government resources with technology, organizations, people, and processes to effectively fight COVID. We work with 23 state governments as an integral part of state government work processes and systems to fight COVID, bringing appropriate interventions to remove bottlenecks to the processes. All StepOne services are offered pro bono to the government. We have a large network of 7,500 plus doctors and 33,000 plus non-medical volunteers working as a part of this process. Till date, we have reached 9.6 million consultations, 2.1 million in the first wave, 6.7 in the second wave of COVID, 0.7 million in the third wave of COVID, and 1.73 lakh mental health counseling has been done so far. 20K medical volunteers for consultancy and 41.6 million citizens have been reached till date with all your help. Thank you so much. Without taking much of the time, I quickly hand it over to Dr. Ramkrishna Prasad for this wonderful session. Over to you, Doctor.
Thank you, Shruti. It's indeed a pleasure to collaborate with Project StepOne. Today's session, so yesterday was World Family Doctors Day, 19th of May. So it's really my pleasure to be part of this distinguished panel. What we will do is we'll run this session as follows. I'll invite Dr. Mohan Kubendra, who has vast experience in family medicine and in administration and many other things, to speak first about the importance of family medicine on being a family doctor. Dr. Mohan, over to you.
Thank you, RK, for that kind introduction. Good evening, ladies and gentlemen. It's a great pleasure to be sharing the platform with all these stalwarts of family medicine, Dr. Ramakrishna Prasad, and especially it's a great privilege to be sharing the platform with an experienced, seasoned family physician like Dr. B.C. Rao. It's always a great pleasure and privilege to be sharing the dais with him. Firstly, at the outset, I would like to wish all my colleagues a very happy Family Doctors Day, which was actually on the 19th May yesterday, where actually we were holding many events yesterday. So that's why we are holding this community engagement program today. Also, I would like to congratulate and wish all the families who are blessed to have their own family doctors. So wishing you all a very happy Family Doctors Day. Thank you, StepOne, for providing this wonderful and a unique opportunity of interacting with the community. I've been asked to give a brief on the development of family medicine and the concept of family doctor and its current status. So I'll be very brief. Well, ladies and gentlemen, we all know that family doctor is not a new concept in India. So for ages and generations, it was the family doctors who were the guardians of the healthcare delivery in the community. And you can remember those days when the community reposed enormous faith in those easily accessible and affordable family doctor, the doctor next door. He would not only act as a doctor to the family, he would act as a friend, philosopher, protector, and a guide, in fact, to the entire family. And he would function as the healthcare manager for all the healthcare needs of the family. We used to have these traditional family doctors. However, during the past few decades, I would say 3-4 decades, the medical profession has seen a tremendous advancement, and with the advancement, also the profession has been fragmented into specialities and subspecialties. There was a huge rush of the development of the state-of-the-art hospitals, corporate hospitals, and these specialists and subspecialists were based mostly concentrated in these hospitals. So this is exactly what has raised the need for having a family doctor. This kind of scenario actually comes with its own problems. With a doctor available for each organ and disease, the healthcare needs of a patient or an individual gets fragmented, and it becomes very cost intensive, becomes very expensive. So it has reached such a stage where, in fact, I would say the people have been forced to reach this stage when they start seeking care, medical care, for even minor ailments in these hospitals for two reasons. One is probably over the period of time they've seen the advancement in the medical profession and the emergence of so many specialists. So probably the public started perceiving that the specialists in the hospitals are more qualified, they're more knowledgeable, and when you are seeing your own family doctor, probably you're not seeing a very knowledgeable and a qualified person. That may be one of the reasons why people started moving towards the hospital. The second most important reason is that the family doctors started vanishing from the community, the practicing doctors. Again, for a reason that even the medical professionals, the medical students, so most of them wanted to keep up pace with the advancement, and they wanted to become specialist and super specialist. So there was a void in the community of the family doctors. This complex scenario, now we have reached a scenario where that family doctors are vanishing in the community, and hospitals are coming up with all the specialists and super specialists. This is exactly what is re-emphasized the need in the community to have a person or a physician who is caring, accessible, but also very knowledgeable. And this is the aspiration of the community, I would say. So they want to see an expert, they want to see a specialist. If you see the traditional GPs, the olden GPs were MBBS doctors, but they were not less knowledgeable. They were very, very knowledgeable. They gained knowledge and skills through years of practice and experience. But now the need of the community and the aspiration of the community is they want to see someone who is perceived to be more knowledgeable and an expert. So the community now needs a physician who can address all the basic health needs, as well as the as well as someone who can guide them to the specialist and super specialist. So that is where the role of family medicine comes. So that is probably the background of evolution of family medicine in India. Such a family medicine also is not a new specialty, but in India over the last 2 decades or so, the family medicine is evolved as a distinct and independent clinical specialty. This probably has helped in realizing the need for a highly qualified, knowledgeable family doctor, which the community aspires to have. So then what is family medicine? Because many of you may not be aware that there is a specialty like family medicine exists, especially in the community. There's still a lack of awareness. So family medicine is it's a unique uh, clinical specialty which is evolved, which is developed on certain principles like comprehensive health care, continuity of care, coordinated care, and most importantly, the indispensable and the core principle of family medicine is person-centeredness. It's a person-centric specialty. Family medicine seeks to promote holistic approach to any medical problem. You come to a family medicine doctor who is qualified in family medicine, he will approach to any of your problem holistically, and he will treat you as a person. The family medicine specialist treat as a person, but not the diseases. He is there to, he's a specialist to treat a person, not just the disease. So we all sitting here, all four of us are the family medicine specialist, I would say. We all have done our post-graduation course in family medicine. So in India also, family medicine courses are being, there are various courses are there, MD family medicine, DNB family medicine. We have diploma courses. So all of us here have done some course in family medicine. And we from the Academy of Family Physicians, we again, all of us represent an organization called the Academy of Family Physicians of India. It is a professional body, a central body, which represents the qualified family doctors, those who are qualified in family medicine. The vision of AFPI is to transform the healthcare delivery through a enhanced level of knowledgeable primary care doctors. The family medicine is growing popularity now. You can see family medicine specialists. You will see in most of the hospitals, even in the corporate hospitals. You'll see now most of the hospitals have the department of family medicine. So the growing popularity of this specialty even among the medical students also now people are coming forward to take the specialty. This development has created a hope for reviving our ancient traditions of general medicine, the age-old family doctor. But now we are looking at new age, the modern family doctor, who is best trained to meet the requirement and aspirations of this modern era. And I have to say this, COVID-19 pandemic has once again re-emphasized the importance of having a very robust primary healthcare delivery system. Even the policymakers have realized, and we are seeing the growing intent by the policymakers and the governments for integrating family medicine doctors, both in the private sector as well as in the public sector, which will is going to have a huge impact on the health outcomes and also on saving cost of healthcare. And it will help in providing seamless quality healthcare in a very complex system now. Also, ladies and gentlemen, now the onus lies with the community also to choose their healthcare provider wisely. I request all of you to help us in reaching the community by embracing this new age family doctors. So next time when you are seeking healthcare, look for family medicine doctors. You will find one. Now we are seeing a lot of many family medicine doctors coming to the community and practicing. So over to RK.
Thank you so much, Dr. Mohan. I have to tell you many inspiring things about Dr. Mohan. Dr. Mohan, he served in the Indian Armed Forces for more than 2 decades. He was a full colonel in the Indian Army and served in the Indian Armed Forces for 22 years. His commitment to reviving and strengthening family medicine and primary care was such that at the peak of his career, he left his army position, came back to Bangalore, set up a practice, and also served as the founding president of the Academy of Family Physicians of India, Karnataka chapter. And under his inspiring leadership, AFPI grew from just a handful of passionate family doctors to over 350 doctors who are a part of this. It's really a pleasure to listen to you, Dr. Mohan. I also know of your tremendous work done during COVID. Dr. Mohan, in his practice, which is Spandana Healthcare, he single-handedly, along with Dr. Shalini, his wife, he single-handedly took care of over 2,000 patients with COVID across his practice, across the city. And he was recently awarded one of the prestigious awards for his service during COVID. I say all these things not to embarrass Dr. Mohan, but to showcase the tremendous contributions that a family physician anchored in the community, responsive and accountable to his patients, can make. I also know that many of his patients are watching this session, and really, I'm sure you'll be fortunate to have a doctor like Dr. Mohan as your family doctor. Thank you so much, Dr. Mohan.
Thanks, okay, thank you.
Dr. Rao, over to you. Dr. Rao, you have been a family physician for over 5 decades in Bangalore. You have seen, there's probably very little that you have not seen. Can you share with the audience and all of us what your own journey through family medicine has been, and what are some changes that you have seen over 5 decades of practice? Thank you.
Thank you, RK, for giving me this opportunity to be with you all, and Shruti for sponsoring this program. You know, it's always not very nice to speak after our Colonel speaks, because most of what I wanted to say has been said by Colonel Kubendra. Nice to have Kubendra as our leader, as RK said. Under his tutelage, we have progressed quite a bit. Now, coming back to today's topic, I'll add a few things that may have been missed by Colonel. See, 50 years ago, when I got into this profession, there were only 2 opportunities. Either you went abroad or you stayed back and worked in the community. Very few of us aspired to become specialists, though there were some specialists, but a few, they were all kind of specialist generalists. The community at that point of time was served by these doctors who became general practitioners. Today we call them family physicians. I was one of them. Those days, we were very well trained, and we could easily come into the community and do most of the procedures and the skills that is presently exhibited by specialists and super specialists were done by us in the community. Now, it was not a big deal for us to conduct a normal delivery or identify a difficult labor, run a drip and maintain it, do procedures like minor surgical procedures, suturing of wounds, do circumcisions, and evert the hydroceles. These are all things which, whatever could be done under local anesthesia, we could easily do. Similarly, now over years, what has happened, this MBBS graduate's skill, his skills armamentarium or his ability to handle difficult problems have been diluted. By whom? See, we have a medical council which dictates the syllabi and the training program, which is mostly sort of, it's dictated by, or the syllabi is prepared by doctors who are not family physicians. So over years, what has happened, most of these skill sets have been removed from the training program, which is given to the MBBS graduate today. So this is on one side. So over years, especially the last 30 odd years, they have become really not very competent to handle problems in the community. So this lack of confidence prevents today's MBBS graduate to take a plunge into family medicine as a profession. This has been identified by a lot of us, and the National Academy also has identified it. And now there is a 3-year program to train family physicians into this. Now this has become a specialty of family medicine. Now coming to the community, you see the community is exposed to a lot of media publicity. Today you see in the newspapers, surgeon removing a tumor of say 30 kgs becomes a big deal. And then you in the community will be greatly impressed, and that only he can deliver the goods. If you get and secondly, you will find that when you are faced with a problem, you don't have a guide to tell you where you should go and what you should do. That family medicine who used to be in your neighborhood has gone missing for reasons I've told you just now. So what happens, he has no option but to go for a complaint which could have been easily handled in the community. He has to go to the hospital. The hospitals today are twofold. One is run by the governmental institutions, in the public sector. The other is in the private sector. Public sector hospitals have been, as you are aware, has been neglected to the detriment of the community's health. Private sector is a profit-oriented sector. I don't blame them, and they will devise ways of improving or increasing their profit. Sometimes my experience is bordering on what I would consider as unethical practices. But then, there is a very gray area to define ethics. To give you 2 examples of recent times. You see, in the hospitals, they have an outpatient setup wherein the patients go, and there is a thing called annual medical checkup. We will discuss in another session the pros and cons of this so-called annual medical checkup, which I consider is a farce. But then there are proponents who want this happen. And a lot of you in the audience also probably will believe in this and go to these hospitals for your annual checkup. In one such checkup, a gentleman was found to have in his ultrasound scan gallbladder stones, which was incidental finding. The doctor who saw, the hospital-based doctor, senior lady, she told him that this is not an emergency or anything, it can wait. If you become symptomatic, that it may need to be removed. Then that is a gray area nearing white, and she erred in the right direction. And then next day, an executive from the hospital comes and tells her that she did a big mistake. She should have referred that patient to the hospital surgeon for removal. And she was given a reprimand note, orally though. And the lady was so, senior woman, was so upset that she resigned from that job. There are instances like this. Recently, our own home care team, which I am associated with, came across a patient, terminally ill, about to die, but the hospital would refuse the request from the relatives to release the body. They would not take the patient out of respirator. And with body means it was just a breathing body because of all the tubes put in. They would say this is the hospital protocol. We have to do this. It took a lot of persuasion and pressure to get. Even then, they would not take the respirator out till the patient was reached home, and they removed the tubes there in the patient's home and allowed the patient to die. Now, what I'm telling this is, despite there are a lot of good things that are happening in the private sector. Some of the best treatments that are available in the world are available in India today. But then, the other aspect of it is you and I, for trivial complaints, we go and sometimes we get stuck. And the expenses that Colonel Kupendra just now told you, what is a fraction that would you would incur in the community treated by a community-based doctor would be astronomically high if you go to a private medical care in a hospital. So this has been my experience. As Colonel said, in case you have a problem, please consult a family physician and don't directly go to a consultant or to the hospital. If you don't have one, I hope after listening to us, you will select one in your neighborhood. Even if it means going to a distance, it's worth going and seeing a family doctor. Thank you.
Thank you very much, Dr. Rao. So clearly, a family physician is not simply a doctor, but he's a trusted resource, he or she. He's also a friend, philosopher, guide with whom you have a long-term relationship and who actually helps you navigate a complex healthcare system and definitely safeguards you against unnecessary tests, unnecessary interventions, unnecessary procedures, and which results in both cost saving and peace of mind. The issue of training has come up several times in both what Colonel Mohan Kupendra spoke and what Dr. B.C. Rao spoke. I'll ask Dr. Gauri Chintupalli, who trained in the UK. Dr. Gauri, what does how is a family medicine doctor trained? What makes it?
Yes,
Yeah.
so I've done my specialization in family medicine in United Kingdom. Over there, the healthcare system works in a different way. So the healthcare system is called NHS.
Dr. Gauri, just 1 second. There seems to be some disturbance.
Is it still there now? Or only while I'm talking?
It's in the background.
Okay, sorry about that. My father-in-law was hard of hearing. Is on the
Oh,
phone
okay.
downstairs.
No,
But am I clear or should I?
Yes, you are clearly on.
Okay.
Please go ahead, Dr.
Yes.
Gauri. Sorry for the interruption.
No, that's okay. So in United Kingdom, the healthcare system is public based. So it is called NHS. Over here, the training for a family physician is a 3-year training after your MBBS graduation. So over here, you go through all kinds of specialities and acquire what kind of skills you need to treat a person. And these people are also based in community and some kind of emergency hospital settings. The way the system works there is any person with any illness, be it a child, adult, elderly, somebody having cancer or any kind of issue, they have to first see their family doctor. As we all know that most of it, 70 to 80% of any illness can be managed in the community by a family physician. They are managed there. Only where we need a specialist input, further treatment is required or further specialist investigations are required, they are specifically referred to a hospital setting, to that particular specialist. So over there, you cannot directly go and see a specialist unless it's an emergency. You walk into the hospital. Otherwise, you have to go through your family physician. So in this way, you're seeing a doctor in your area. You're not traveling, and it is the waiting time, and you don't have to undergo unnecessary investigations or treatments and be passed on from one specialist to another, as some of the ailments can have multiple factors. It could be related to multiple organ systems. And as specialists are more focused onto particular organ system, they will screen or investigate that organ system. When they don't find anything, you're passed on to another. So as a family physician sitting there, we are getting all these reports and everything back to us. So we screen, we convey things to the patient, and we integrate everything what is happening even in tertiary care and explain to the patient, handhold them. So there is this very nice trusted patient doctor relationship that goes on. So you know them, you know the family, you know how and what to modify and apply what is needed for this patient and guide them further.
Thank you, Dr. Gowri. That was nicely explained. I'll take the first question from a live audience member. So Mr. Satish Rao has asked a wonderful question. He says, GP or FP, a general practitioner or a family physician, who should I consult for routine issues like diabetes, blood pressure, high cholesterol, etc.? Dr. Mohan, would you like to take that question?
GP or a family physician, general practitioner, I don't know what he means by GP or FP. Is he referring to general medicine specialist or a family medicine specialist? If that is the question. I think you should consult your family physician because for the family physicians of this age, the family medicine qualified doctors are trained, well trained to address the chronic disease management. Not just the chronic disease management, the curriculum of the family medicine includes all the aspects of the health, right from children to the geriatric age group. The pediatric healthcare problems, the adolescent healthcare problems, and geriatric healthcare problems. And the chronic disease management is one of the main competencies which the family medicine trainees are trained in. So you must see your family physician. And also the family physicians of this era, that is the family medicine specialists, they are expected to keep themselves updated on the latest, and they generally go through some kind of updatation courses in various aspects like the diabetes management or chronic disease management. So family physicians are the first, the ideal person for you to consult for diabetes, hypertension, and cholesterol problems.
Thank you, Dr. Mohan.
Most of the family physicians have an area of special interest also. Like you must have heard that GPs with special interest. Many of the family physicians have, although they function as general practitioners, they also identified their area of passion. So many of the family physicians are functioning as diabetologists. You don't need to visit the consultant endocrinologist or internal medicine specialist for the chronic disease management. The family physicians these days are very well trained, and they have the knowledge and skill to manage the uncomplicated cases of the diabetes and hypertension.
Thank you, Dr. Mohan. Actually, that's a great point. In fact, if we look at this panel of family physicians, Dr. Mohan, in addition to being a family medicine doctor, is an expert in the management of diabetes. That is an area of special interest. Dr. Gowri, in addition to being a general practitioner, family physician, she's also an expert in child development. As we go along, I'll request Dr. Gowri to speak about that to some extent. I myself have expertise in infectious diseases, particularly HIV, viral hepatitis, etc. Dr. Rao, I'll take a second question, which is from another live participant in our session today, Ms. Sudarshana Suryanarayan Shetty. What is the difference between a comprehensive line of treatment and an aggressive line of treatment? I think it's a wonderful question.
See, let us say, take an example of both. Let me go to this aggressive way of treatment. Now, for Mr. Shetty, now let's say you get a bout of fever. Now you go to an elderly or a senior doctor like me. I will first find out what is the nature of illness, how high is the fever, what are the symptoms like. And if I find everything is all right, but the fever is there, I will probably tell you take some paracetamol tablets, drink plenty of liquids, take rest, and see me after 3 days. This is not very aggressive treatment. This is simple, comprehensive treatment, considering all aspects of the illness and coming to a conclusion. Aggressive treatment is, at the outset, you shoot the patient with a fever-reducing injection, give him a course of, start with an antibiotic course, maybe add on a steroid also to that. This is I call comprehensive treatment, which is actually not in the interest of the patient. That's one aspect of comprehensive treatment. Other is to find out various aspects of the illness and to investigate and find out what is the problem. Both these come at a later date of the illness and not the immediately after you see a doctor. I'm not very sure if I have answered your question, but then aggressive treatment, many cases should not be undertaken unless there is a need for it. Let us say you go to a doctor with a right-sided lower abdominal pain, acute tenderness. There you can't be doing this, I will wait for 2 days and see what's happening. There you have to go in and take the appendix out. So your doctor will decide which is comprehensive treatment and which is aggressive treatment.
Thank you, Dr. Rao. I think the main take home which I heard was sometimes determining this requires judgment of a trusted person who is also a very competent person. And the focus is on what is appropriate. One should neither overdo, because there are risks and costs associated with overdoing things. At the same time, one should not miss significant findings which require urgent or immediate attention. Dr. Mohan or Dr. Gauri, would you like to add anything to this question? I'll tell you what I think this question highlights. For the public, one doesn't know where to go, and especially in time where you get so many messages through social media. There is lots of advertising. You hear about big hospitals. You hear about fancy technology. Doesn't know what to trust. Obviously, for yourself or for a family member, you want your family to receive the best. You don't want your family to receive negligent time. You want it trustworthy, appropriate, and cost-effective. So I think this question really hits the heart of that. Your comments, both your comments, maybe Dr. Kavi first and Dr. Mohan.
So Dr. Rao has already brought out the aggressive approach when it is required. I'm just giving an example of a person who is, this is a very common example, it's a person who has headache. So like Dr. Ramakrishna already brought out, he is now confused with so much information. He goes to Google and puts headache. What are the causes of headache? There are multiple causes of headache. And what really strikes to him is that a tumor, a brain tumor. So should I, then probably he said, okay, let me go to a corporate hospital. Let me get an appointment with the neurologist. So he goes to the hospital, then he goes to a neurologist, then neurologist will see from his perspective, say, okay, last for an MRI, and then, okay, MRI comes normal. Then he says, okay, from my side, you're clear. You better go to the next specialist. So he keeps moving from one specialist to other specialist. So if the same person comes to a family physician, so there are different causes for, he looks at holistically, and not that the neurologist does not know what is the commonest cause of headache. So there are different causes of headache. The most commonest being simple headache, tension headache, then headache due to hypertension, the problems of eye problems leading to headache, the sinusitis. So the family physician looks holistically and he gives a comprehensive angle to the way the comprehensive advice, and he will go methodically. So only if the symptoms are suggesting that yes, there is something serious, then only he goes to, he'll refer to the specialist. So I think that is where the role of family physician comes in, because especially these days, your access to information is so much, and the information is the one which is causing so much anxiety, and so your family physician
Stress
can be
factor.
yeah, it's a big stress factor.
Okay, to add on to this, I think what Sudarshana here would like to know is, in hospitals, they prefer aggressive line only unless request for comprehensive treatment. So to add on to that, when you go to the hospital to a specialist, they are very tuned to look at all the worst case scenarios. They are trying to look into everything and manage. So they are more, that is why they tend to go more aggressive. So sometimes it is good, sometimes it is not relevant. So like everybody else is mentioning, it has to be looked as a comprehensive, totally, to see why, what is happening, and then try to differentiate what kind of therapy this is required. So will our community-based treatment is okay, or you need to go to the hospital for aggressive. So we have something called red flags. We look out for them. We screen you. If need be, we send you for this aggressive line of therapy. So a lot of the hospital that manages are in these lines. So it is difficult to say or blame hospitals, and it is when they go there, again there is expectation from patients also. So if nothing has happened, you just give a prescription reassurance, and sometimes it is the other way around. So the patient expectations should also be taken into consideration and seen. So if you have a point of contact where you know, where you can trust, again you say they only tend to aggressive line of treatment. So again, I see that lack of trust with these doctors. So when you know you're going through a channel where you can trust, and then you're going there, the way you approach is, take it, is also better.
Yeah, thanks, Dr.
And I just want to make a point here to the public that the family medicine specialist or the family doctors, we are not against the specialist. So what we are saying is that specialists are required. They are experts in their own area of specialty. So, but what we are saying is that their services should be optimally utilized for the thing which is actually required. You go to a specialist for a thing which is not required to be seen by him. You are wasting his time. You are wasting your time. So we are not against the specialist. You go to specialist through the family physician is what we are recommending.
No, thank you very much for adding that, because ultimately all of us, patients, doctors, family physicians, small hospitals, nursing homes, large corporate hospitals, specialists, we are all part of the healthcare system, and none of us are at odds or or in a fight with anyone. It is the appropriate utilization of the right resource at the right time to affect the right outcomes. That's what this conversation really is about. I'll actually take the example of headache. Just last week, one of my patients who is about 60, who's otherwise in good health, he has high blood pressure, which is well controlled with one medication. He developed a headache. And he's normally very active. He goes for a walk in the morning, and and his family members texted me. They said, "Doctor, he has not been able to get up for the last 2 days." This was very unusual to me because I know him for the last 5 years, both as someone as his doctor. I also have a relationship, and I know several members of his family. There was something in me which said I need to go and see him. So actually, I made a home visit. I went and saw him. Just like Dr. Mohan explained, I took history. I sat with him. I asked him when his symptoms began, what was the type of headache, where was his headache. I examined him. And he has a history of a sinus problem. So he thought it was a sinus problem. But one of the things I noticed was when he was lying down, his headache was much less than when he sat up or stood up. And this made me wonder, what is going on. I observed for a few more hours, and then I became concerned that there could be something more than simply a headache, which would go away with a painkiller, like taking paracetamol, that is Crocin or Dolo, or even ibuprofen or an anti-allergy medication or anti-migraine medication. So this is when I discussed with him. I explained to him what I was concerned about. I recommended an MRI. His question was, where should I go? So one of the things his family doctor I did was I made a phone call to a hospital or an MRI center where I have a trusted colleague who's a neurologist, and a facilitated coordination so that it would be easy for my patient. And then I also facilitated communication with a specialist. I called up a neurologist. I discussed the case with him. So these are all roles that a family physician plays. And eventually, when the MRI was done, it was noted that there was a subdural hematoma. That is, there was a blood clot inside the skull. So, but because of all this, he could immediately be seen by a neurosurgeon who communicated with me. And then he got surgery done the same day, and now he's back home and feeling much better. So I use this example to illustrate the various roles that a family doctor plays, including person-centered care, whole person or comprehensive care, coordination of care, contextual care, where this is the person, this is the family, this is what is going on, and of course all this based on a relationship. And the doctor serves as the point of first contact. What we will do in the remaining half an hour or so that we have of this session is many of you have sent us questions in advance. And looking through your really well thought out questions, there were 3 or 4 broad themes that the questions could be arranged in. There were several questions on COVID. We will take them. There were also a few questions on diabetes and hypertension and chronic diseases. We'll spend the next 15 minutes or so in discussing a few questions related to chronic medical conditions like diabetes. So, Dr. Mohan, I'll ask you this question. This actually is a burning question, and many people ask me. They say, look, I have been diagnosed with diabetes. A doctor or someone, I've read that this is a lifelong disease. I have to live with it. But doctor, is it possible to reverse diabetes? So, Dr. Mohan, can diabetes be reversed?
Okay, it's a very good question, and this is a very common question which at least I get from my patients. Many of my patients newly diagnosed mostly, and even some of them who are already diabetic for a long time, they also come and ask me, doctor, we are hearing so much about diabetes reversal. Can it be reversed? So firstly, we should understand what is diabetes and what are the different types of diabetes. So there are 2 types of diabetes. One is type 1 diabetes and type 2 diabetes. Type 1 diabetes, there is an absolute insulin deficiency. So that cannot be reversed. It is not reversible. Let us be very sure on this. And the type 2 diabetes, which is a lifestyle disease, and most of the diabetes, almost 90% cases of diabetes are type 2 diabetes cases. So type 2 diabetes is also a progressive disease, and we all know that it is not a curable disease. It is just a controllable condition, I would say. But the good news is that, yes, it can be reversed in the sense that you will be with some interventions like diet, exercise, which aims in getting your weight down to reduce your weight. You'll be able to reach and hold your blood sugars in the normal range without medication. So that is what probably we can call it as diabetes reversible. So this is possible. This is possible at the pre-diabetic stage. This is possible even someone who is diabetic for considerable period of time. But what you should understand is that firstly, this requires a lot of dedicated, disciplined, and motivational effort by the patient to bring down your sugars to normal level, pre-diabetic levels, through all the lifestyle interventions. That one should know. And also one should realize that diabetes reversal does not mean that you are totally cured of diabetes. The diabetes re-reversal is also possible, in the sense, I see many of my patients who go through this reversal programs. These days it has become, it's in the news and social media, so many diabetes reversal programs. They undergo this reversal program and they attain the normal pre-diabetic blood sugars. And after that, they think that they are cured of diabetes and they stop the medication. Of course, they would have stopped during this program itself. And they stop even monitoring their sugar levels, thinking that they're cured of diabetes. And then one fine day they come back with very high blood sugars and the weight coming back to their pre-program levels. So re-reversal is a possibility. So I would not call it as reversal. We can call it as diabetic remission. Okay, this is not reversal actually. This is a remission. That is in remission phase as long as you are putting all your effort to keep it under control. And once you stop that, you are back to square one. So this is not reversal. It's more of a remission. I hope that answers the question. But we do not discourage people to go for the diabetic reversal programs. See, anything which you can sustain, if you are motivated enough to maintain what you've achieved during the reversal program, then you must do it. So we don't discourage, but you should be aware of the fact that if you stop doing what you are expected to do in these kind of programs, then it will come back.
Thank you, Dr. Gauri. One of the questions sometimes people ask is, should I undergo weight loss surgery to reverse diabetes or bariatric surgery? Could you share your thoughts on, when is bariatric surgery or weight loss surgery useful, and what are some benefits that can be expected? And what are what are situations where bariatric surgery is not appropriate? Thank you.
So as any procedure or anything we do that is not natural or normal process for our body has its own risk and benefit. So it's always about weighing this risk and benefit before choosing, yes, this is the right line of therapy for me or not. Because this is a surgery, as a surgery, it has its own risk involved, but it has its lot of benefits as well. So as Dr. Ramakrishna Prasad has mentioned earlier, the right kind of therapy at the right time is what is ideal. So people who are really struggling, who have a lot of issues, so really overweight, They have tried all the lifestyle factors, what they need to do. In spite of that, their sugar levels are not controlled. They're on multiple medications, insulin. They're having other comorbidities, what we call, either involvement of heart or other organs, and the maintenance of the sugar levels or their health conditions is really vital. It is not happening, then this kind of a surgery can really be beneficial. So where over here it helps with the weight reduction. With weight reduction itself, we know that the sugar levels come down. The blood pressure or even other chronic health condition can be actually maintained with weight reduction. So this thing can be helpful. But again, as Dr. Mohan said, and again, even bariatric surgery is also known as diabetes reversal. Some of them use it for diabetes reversal as well. But over here also, as Dr. Mohan Kubendra has mentioned, you have to still continue to follow a diet, because the size of your stomach, there are different varieties. So based on that, the amount of stomach left behind, or where the operation and the joining is happening, you will have to be on supplements lifelong. You have to maintain your weight. You have to be motivated to follow the diet. Otherwise, yes, you can still gain weight. It can still, the reversal can happen. So that is why a lot of pre-surgery counseling is required to motivate, follow a diet for certain time, and then going for this surgery. So it has its benefits, but you have to, for sustained effects, you have to follow up and maintain. So in that way, we know you can come to us often. We are quite accessible. So when you are having those slowdowns, we are there to kind of help you and guide you. So for whatever procedure, whatever chronic health conditions, that is where our role plays a vital factor, because it's not just an illness. It has a lot of psychological impact as well on the person, on the family. So if this person has to maintain that diet, imagine the person who is has to kind of cook or is in charge of the kitchen. They have to kind of make separate provisions, or the whole family is changing their diet. So there's a lot of things involved. So it has to be well thought before you take this kind of step.
Thank you, Dr. Gauri. I have one more question for you, and after that, I have a question for Dr. Rao. Mr. Brig Chopra has asked a wonderful question, and in fact, in the questions we received before the session, there was a lot of interest among others in knowing the value of yoga, pranayama, and meditation in controlling blood pressure, diabetes. Could you please respond to this question, which Mr. Chopra has asked?
Yes.
Can blood pressure be reversed with yoga and pranayama even after a few years of medication? Or at least, can the medication dosage be reduced by disciplined lifestyle and perhaps the use of practice of yoga, meditation, and pranayama?
Okay. So to begin with, to answer this question, we need to see why we are having so much of chronic health conditions these days. It is all basically, a lot of it revolves around your lifestyle. So when we look at the way our lifestyle has been changing over the years, so our physical activity has come down. We have machines to do a lot of things. Now we are glued to our seats with a lot of online presence, doing a lot of things online. And so our activity levels have reduced, our eating habits have changed. The kind of outlets we find on each road is humongous or tremendous. So we tend to, our lifestyle is deviated. And on top of all that, our stress levels. So we know the stress levels itself adds or is a major factor in contributing to any of this kind of lifestyle diseases, may it be hypertension or diabetes or even cancer, everything. So there's a lot of changes that has happened around us, and these things are having a detrimental effect on our body, on our health. So does yoga, pranayama help? Yes. When we see any patient with such chronic illness, the treatment is not finished without a lifestyle advice. So what you can do apart from medication. So that includes physical activity, how to control your stress. Again, stress everybody has, but it is about how you can manage it, what all you can do. So any form of exercise helps or produces these kind of hormones, which helps us relax, feel better, gives us a clearer mind to think. So yoga pranayama is those forms. So in yoga itself, when you look at what yoga is, it is a form of, it's a Sanskrit word where it means it is a unison of soul and divine strategy. So what it involves basically is asanas, that is the exercise, physical body postures. Then you have the pranayama, which is the breathing exercises, and there is dhyana, which is meditation. So it incorporates all of these. And what is ideal to you, what you can practice, you can adapt to it. And again, in meditation, even in yoga, pranayama, there's so many different varieties. So it is about choosing what is right for you, and these things can definitely help. The stress level comes down with the physical activity, your general well-being is better. And yes, initially, especially in the starting stage, even we screen whether we need to start medication or can we try this lifestyle medications and see whether you need medication or not. So we can monitor. So being by your side, we can monitor things and then advise. And many people, yes, we do see that we can reduce medication dosage as well, who have been on it for long, and where this lifestyle issues can be addressed. So this definitely has a role.
Excellent, Dr. Dowdy. Dr. Rao, you didn't seem very enthusiastic about the master health check. But one of the questions that a few people have asked is, what are some checks, health checks or tests that someone should do or should discuss with a doctor at different stages of their lives? And if you advise certain tests which are thought out for screening, what are those tests for both men and women, and at what stage of life? Thank you.
Yeah, actually, this is a very a large question. The screening for disease is a subject for itself. So I will briefly touch on this. Yes, I agree that there are certain mandatory tests that are to be done. There are lots of tests which are not really required. I think Shruti will have another session based only on this screening for disease, when to do what. But just today, to answer this question, let me give you a few examples. Let's say a person who smokes, and then we need to screen him. Screen him with what, how frequent, and with what. And if that person has a family history of lung disease, let us say cancer of the lungs, this person has to be screened. I would screen him every year with a chest X-ray. But I would not do this chest X-ray for a person who has no history of smoking. Because doing a chest X-ray means exposing him to a certain amount of radiation. But the damage caused by radiation is infinitesimally small, considering the risk that man is running by inhaling tobacco smoke. Therefore, in this case, screening for disease of lung cancer or other problems related to smoking is absolutely required. I'll give you another example. The lady who has got a family history of her mother, grandmother having breast cancer, it is mandatory that she should be screened for possibility of breast cancer. Similarly, there is a generalized screening that is required for certain diseases. Now, for example, let's say age onset prostate enlargement. You would like to see if there is a possibility of cancer prostate. You don't do that every year or so. There is a frequency, there is a laid down protocol which you follow. Same thing, there is a family history of diabetes, let us say. It is known that people who have a family history of diabetes have a higher incidence of developing diabetes. In those patients, screening for disease, development of diabetes is mandatory. And there are certain screenings which are generally done during pregnancy, for example. It is mandatory to do ultrasound scan periodically to explore possibility of fetal illness. So, who is the person who decides on when to do and what? That is where your family physician comes into the picture. He is the person who will not only screen you from unnecessary diseases, but also will screen you for necessary diseases. He will prevent unnecessary procedures being done, unnecessary tests being done, but he will see to it that necessary tests are done at the required time.
Dr. Ramakrishna, can I add here?
Please, Dr. Mohan. And Dr. Mohan, if you could turn your video on.
Sorry. So these days we are seeing a lot of hype on this preventive health check. So the hospitals and even the laboratories, the diagnostics, they come up with this master health checkup, comprehensive health checkup, and all. There's too much of hype. Not only by the hospitals, even the companies, the corporate companies, they make all their employees, irrespective of the age. I have seen people in the early 20s being made to go through the preventive health check. And we do see some of the families coming with the preventive health checks for the entire family, irrespective from children to the elderly people. So this is definitely not required. This is, what happens when they undergo these master checkups? They see the reports. There are some labs which give 500 different parameters are tested, and some of them are in bold. So they get anxious. They put it in Google, and there's so much information on your the magnesium levels, arsenic levels, and all those things. So we are not against preventive health checks. Preventive health checks are required. Screening, as Dr. Rao has rightly brought out, screening is required, but it needs to be customized to the needs of the individual. So even as the company doctors, my request is to guide these companies, the corporate companies, to guide the thing, to have a screening protocol and screening periodicity. Like in armed forces, we have a periodicity. It starts at 26th year, one this health check. Then every 5 years, we have that periodic health check. That's a comprehensive profile. And every year, he needs to go through a physical examination by his family doctor, his regimental doctor. So I think we need to have this kind of system even for the community. Maybe every 3 years in their 30s, probably every 2 years in their 40s, and maybe every year. And also, it is not a good practice to see your family doctor with the master health check report. Already you have done the test, and then you're coming to your own family doctor. Doctor, I have done all these tests. What is your interpretation? I would suggest that you see your family doctor before even you are thinking of getting this the preventive health check. Then the family doctor, he knows your family history, and he knows what screening tests to be added, which package to choose. At least if you are already decided to go for package, he will guide you. Okay, you go for this. These are essential tests. So I feel there is a need to customize and to the needs of the individual patients as far as this master health check, preventive health check is concerned.
Very well said, Dr. Mohan. As Dr. Rao said, we'll have a separate interaction specifically on this, because I think there are lots of questions on this. We as family physicians, almost on a daily basis, we see people with a master health checkup report, and people ask a lot of questions. One more question for you, Dr. Mohan. Many people, conditions like hypertension, diabetes, high cholesterol, obesity, etc., smoking, these are all associated with heart attacks. And then, chest pain, heart attacks. And in the recent past, we saw the death of a very famous actor in Karnataka, which has really raised the awareness and also anxiety about chest pain and heart attacks. So many members of the public wanted to know, how do they know their own risk? Are there ways by which a family physician can guide people to be able to assess or evaluate their own risk of a heart attack? If you could respond to that.
Yeah, there are certain factors which will increase an individual's risk for the cardiovascular diseases. So mostly there are about 6-7 risk factors one should be aware as a public also. That one is your age, your height and weight, what we call it as body mass index. If you are obese person, overweight, then your risk increases. Then if you are having high blood pressure, that is hypertension, diabetic, if you are a smoker, these are the risk factors which will, these are the factors which will increase one's risk for having the cardiovascular diseases. So there are methods of assessing your risk, the level of risk. So there are various method of scoring your risk. We call it as risk stratification. So I generally follow a simple this thing. If somebody is asking me, out of these 6 risk factors, if 3 are positive, you should be a little watchful. Probably your risk is at least 10 to 15% more than the normal individuals. But there are various different risk analysis scores. These are available online. One of the most commonly used is Framingham risk score. So it takes into consideration the cholesterol, your age, your weight, and your smoking history and all. So it gives you the individual risk for having cardiovascular disease in the next 10 years. So somebody who has 10% risk is considered as low risk, and 10 to 20% is considered as intermediate risk, and those with more than 20% is considered as to have high risk. So these are the risk factors one should consider, should be aware.
A follow-up question is sometimes when people experience chest pain, they can't differentiate between chest pain because of a heart-related issue, such as a heart attack or cardiac issue, and heartburn. Are there some ways that members of the public can distinguish between the two? Dr. Mohan.
Yeah, so severe heartburn and cardiac pain, we call it as angina in the medical terminology. It's very difficult to, very hard to differentiate by the patient. Even for the doctors, sometimes it is difficult. What we need to understand is how they may differ in their presentation. And to learn, you should learn how to get immediate help when you feel that this is cardiac pain. If you are not understanding, if you are not aware of this, for any time, every time you have a heartburn, maybe probably you rush to the hospital and you end up getting yourself evaluated with certain tests. So one should know what may be the differentiating factors, symptoms between these two. The typical feature of a heartburn is basically a burning kind of sensation in the chest, in the upper chest, in the middle of the chest, and it usually occurs after eating something heavy or something spicy, or even normally also after eating it might happen, and it is aggravated when you are lying down or when you are bending. Although there may be overlapping symptoms, features like it may also radiate to the back and shoulders. But typically, this is how a heartburn presents. And generally, they respond to the antacids. They are relieved by taking an antacid. And mostly it happens within 2 hours after having your meal, especially during the dinners, after the dinner. A typical anginal pain or the cardiac pain presents the kind of pressure or a tightness in the chest, kind of squeezing pain. Of course, it might present, we call it as atypical angina, might present like a heartburn, or maybe they may present with vomiting, but mostly it causes kind of pressure, squeezing pain, tight neck, jaw under the left shoulders. Mostly associated with shortness of breath, and it is mostly exertional, and they may present with lightheadedness or dizziness. These are some of the features from where we can differentiate a cardiac pain from the heartburns. One of the characteristic thing, what I have seen in my practice is that whenever they have cardiac pain, they have fatigue. It's a very typical this thing. Like I had a patient just 3 days back. He is a regular patient with an acid peptic disease. Generally gets these heartburns and takes antacids. But just a couple of days back, he called me at around 12 o'clock in the night. He said, "Doctor, I'm having the same heartburn, but it's not relieved by antacid." He would pop some antacid or some gel, it would relieve. But this time it is not responding. So I just asked him, so is there any difference, like you are used to getting this? What do you think? What is something which you have not experienced? He said, "I'm feeling very tired, doctor. This is very unusual for me. I'm having this problem, but I'm feeling very tired." So then I said, okay, that one question you should ask is that, are you feeling the same way as you generally have heartburns? So they will come out with something different. Either they'll say, okay, I was sweating, they'll say I was little breathless, I was feeling breathless, or they may say fatigue. Fatigue is one symptom I've seen that. So immediately I said, okay, please go to the nearest emergency and get an ECG, and it was a case of myocardial infarction or a heart attack.
That's very valuable to know. I think also there is sometimes a clue in the timing of the call. You know, someone called me, definitely in my practice. I liberally share my phone number with my patients. But I must say, it's very rare that patients misuse access to my phone number. But sometimes when I receive a text message or a phone call, close to midnight, there's usually something happening, and I take it seriously. Dr. Rao, in your decades of experience, how do you what are your experiences and views on patients reaching out to you at odd hours, and as a family physician, how do you do it?
I agree with you. If you get an off-hour call, especially in the nights, if you're in practice for a while, your patients know you, and that, as Gauri told you, the trust is built up, and then they rarely misuse that trust. Of course, occasionally they do, but then when you get a call middle of the night, I would take it extremely seriously, and I would err on the right side, even if I'm sort of called a bloody fool afterwards by my friend who does the ECG and does it later. I do that. But then coming back to differentiation, so the first episode of a burning sensation is always very difficult to differentiate between a cardiac chest pain and a non-cardiac chest pain. But if there is a history of repeatedly getting acid eruptions to the mouth, and then, rectus tunnel, pit of the stomach burning, you can take a chance if the blood pressure is maintained, there's no sweating, no other thing. Do a resting ECG, wait for 4 hours or so, do another ECG, both are normal, zymes are normal, then you know that it is a non-cardiac chest pain. This is especially true in doctors practicing in remote areas, no access to hospital care. Hospital is 100 kilometers, 50 kilometers away. What they should do, they have to follow a different protocol than what city-based doctors follow. All said and done, yes, don't take, we family physicians are trained not to take a chance, despite the fact that we are there to safeguard the patient's interests. But when it comes to a life and death question, of deciding whether the person is having a heart attack or not, it is better to err on the right side.
Thank you, Dr. Rao. Well, COVID, how can we not have a session? How can we have a session and not speak about COVID? So, Dr. Gauri, this is a question which has been asked. Is the COVID booster dose really necessary? It appears so some say it appears that COVID has ended. Has COVID ended? Can we stop wearing a mask? Is the vaccine booster dose useful? Over to you.
Once this has come in and become a pandemic, the COVID, there is actually no end to it. What we call is the pandemic has become endemic. So initially when the virus has come attacked us, none of our bodies have been used to it or aware of it. So our bodies or our immune system, the fighting system in our bodies don't know what it is. So they have also been chaotic in responding to this virus. So that is why we've seen the bad reaction in the first and the second wave, where we've had a really difficult time. A lot of us have faced a lot of issues, needing hospital admissions, seeing a lot of deaths there. But as you've seen in the third wave, even though the number of cases were much higher, the hospital admissions were much less. That is because our bodies now know about it. Our bodies have our immune system, our body's defense system have built up a fighting mechanism to recognize this virus and fight it better. So that is why we are seeing it lesser and lesser as they evolve. So like you have seen, there is a new variant. These viruses are very notorious. We know they mutate, they change, the genes in it changes. So as it is changing, they also look to survive. So if our body mechanism is also very strong, they are also, so they don't cause too much of a serious problem as well. So it has been changing, as we have seen in the past with similar thing, where we have seen this flu exactly 100 years ago. Even when it came in, it was a pandemic. Initially, there were a lot of issues happening, but as the years went on, its intensity or its effects have come down. So even now, when we see people at high risk of having trouble if they contract this flu, we have flu vaccines. So there are certain criteria and people who we give flu vaccine to. In a similar way, there is a COVID. We all needed to get vaccinated so that our body defense system or our immunity gets a small dose of it, not the actual virus. So our body has built up this immunity to fight this virus if we get it. So it is not that you have had the vaccine, you will not get COVID infection. You can still get the infection, but the likelihood of it getting serious is much less. So let me give you a little example. So when we go through schooling, we have learned so much is going on. But now if you ask a simple question of fifth grader, you may not remember. That is how what we call memory system of our immune system. So if you read it again or come across it, you will remember it again. So in a similar fashion, when we call a booster dose, this is what exactly the vaccine dose is doing. This is what we exactly want. So our immune system doesn't lie dormant. And again, we see the mutations happening. So when the vaccines are prepared, they are modified to incorporate these changes. So our immune system is getting used to the advances also. I can say advances. And as I said, COVID is not over. So you have to take your precautions. Anybody having a fever, cough or cold, I think you should take the responsibility and stay away from people so that even if it is COVID, it is not spreading and becoming a big major issue and making us all wear our mask back on again.
So neither Dr. Rao nor I have any symptoms. And when we see patients, I take the metro sometimes, I always wear a mask. I always wear a mask when I see patients. And even in my consultation room, We have good cross ventilation. I keep the windows open. The distance between me as a doctor and the patient is typically more than close to 2 meters, actually 1.5 meters or so. So these are all precautions we are following. And just in case you're wondering,
like the way we practice has changed post COVID. The way we live also has to change. I think it. So the mask is there to stay with us. So maybe we can use it where it is required. Maybe we cannot expect people to wear mask all the time everywhere. Maybe wherever there is a high risk environment, I think they should continue to wear a mask. Also, another questions we keep getting about these vaccines. When should we get, especially people who have been infected, when to take the booster? Is there a need to take a booster vaccine? So these are very common questions we get. So if anybody is infected with COVID, maybe there is no need for taking a booster for at least 3 months, is what I feel. What is your take, Dr. Ramakrishna? Because some people say boosters can be taken after 1 month, after 4 weeks, you should go for booster. But what is?
I agree with you, Dr. Mohan. Especially 2 months back, a lot of people got infected in January, February due to Omicron. And we know that from the immune response, if you give a booster dose too soon, it's largely ineffective. Doesn't really cause any harm as far as most of us know, but it's unlikely to be effective. And in some cases, it even blunts the peak of the immune response, the antibody response. So I agree with what you've said. The other fact is COVID antibodies, what we've learned are fairly short-lived. So after about 3 to 4 months, most people lose their, at least their antibodies. But as Dr. Gauri mentioned, there is still memory
is there,
which is still useful. I don't actively dissuade anyone from taking the vaccine, taking the booster dose. And definitely those with comorbidities, older individuals, I do encourage them to take it. But I do acknowledge that the evidence is not entirely clear. So I think we've come to the end of our session. I see that Shruti has turned on her video as well. So there were some other excellent questions, but what I will promise is that this is not a one-off event. We look forward to engaging regularly with you. I think all of us really enjoyed this. And I particularly want to thank Mr. Satish Rao for giving us a wonderful suggestion. From the Academy of Family Physicians of India, Karnataka State Chapter, we will do as he has suggested. So he has asked that sometimes it's difficult to know who is a practicing family medicine doctor near him or his family. We will create a database and we will put it up on our website. Academy of Family Physicians of India, Karnataka State Chapter has a functional website. We will put up a website and a list of all the doctors and their practicing addresses so that you can, and their phone numbers, their office phone numbers, so that you can access them and utilize this resource. Shruti and Project, we really thank you. And we look forward to doing this many times over the coming year. So please stay tuned. Over to Shruti. Thank you.
Thank you so much, doctors, for coming on to this panel and answering all those questions with so much of patience. And we see that the questions were amazing as well. There are a few live questions that came up. There are a few pre-sent questions that you answered. I think all the questions were amazing as well, which as common people, we all can relate to. And the way it was answered and the advice that we received were absolutely amazing. So thank you so much. And we see in the chat box as well that people are loving the session and they're sending their comments saying this is a very useful session, the way it was, and thank you for the right advice, and so everything. I think okay, doctors, we also received a reply from Satish Rao saying thanks in advance for promising an AFPI directory. So we can see that people are actually liking the way this was very educative and very helpful session for all of us. So thank you so much for taking time off your busy schedule and doing this wonderful session for us. I'm sure 1.5 hours is I think 1.5 hours was just spent like this answering all these questions, and we did not feel that we have actually sat in front of a system for listening for 1.5 hours. So this was very interactive. I must thank the panel of doctors here, Dr. Gauri, Dr. Mohan Kubendra, Dr. R.K. Prasad, and Dr. B.C. Rao for coming all the way and doing the session for us. Thank you so much. We look forward to many such events with AFPI, and of course, Project StepOne is always here. So thank you so much. Take care, everybody.